And we're back. Welcome back to the podcast. How are you, Jerry?
I'm doing really well. How are you, Tamara?
I'm good. Is your coffee still hot?
It's very hot.
Okay. All right.
Scalding.
Oh, so we're ready to go. You're caffeinated?
Yeah, I'm properly caffeinated. I'm ready
to go. Or we're going to talk about one of my favorite topics today because not everybody has the experience with finding a good provider that I did. I was, my first try, I came to Optimize You. So, pro tip. But if you can't find an Optimize You clinic, or you're just looking for a good provider to talk to you about your hormones and you want those optimized, we want to talk about just a couple of questions to ask, like things to look for to pick the right place, and maybe some red flags to also watch out for.
Are we talking about males and females, just patients in general?
Both, patients in general.
Okay.
Yeah, I know some of the things that we want to talk about are specific to
It can be.
But in general, wanted to ask you about just some general questions that you should ask as you evaluate different providers.
Well, I think today, as if you can't, as a provider, evolve with the literature. So if you're still clinging to using mercury on people or lobotomizing people, I mean, clearly we know that's not the right approach to take. So same with hormones. If you're still clinging to the Women's Health Initiative, if you're still, looking at old data, prostate cancer data from the Huggins study in 1940 or 38, question mark, right? I mean, I think it's important to know where we came from because history can repeat itself, but it's also important to look at recent studies and evolve as the literature kind of dictates with us, and the guidelines evolve as well. Hence, the 2018 guidelines were different than the set before that. So I guess I'd say big, giant, low-hanging fruit here for me. If you're going somewhere and you're a male on testosterone and they're wanting to block your estrogen using like a Remedex or an Anastrozole, rather, like, what are you doing? Like, this is a problem. You're causing harm with an AI. Stop doing that. So that's one for me. Another one is if you're going somewhere and they're not ever looking at free testosterone, they're only looking at total testosterone. Why are we doing this? What are you doing? That's craziness to me.
Yeah, and explain the difference and why that's important.
Well, I think we've said it in other videos, but let's do it again. I mean, total testosterone is just what it sounds like. It's all the testosterone the machine can find. But what we know now, after, say, the mid-1990s discovery of the bound hormone hypothesis, about 95 or 97% of your hormones, particularly testosterone, are bound or encaptured into this protein carrier group. Think of it like a storage box. And when the hormones, particularly testosterone, are in or on the storage box, you can measure them, but they're inert. They're not working at that moment. They have to detach from that and become free testosterone. Another buzzword you hear is bioavailable. It's not necessarily the same term that has to do with albumin-bound testosterone. But anyway, free testosterone is ready to use at that moment. One of my favorites is the storage analogy. So you took your winter clothes and you put them in a box, and you know how many you put in there. I put 5 sweaters in the box, but they're not usable until you take them out of the box, right? Same with the testosterone. If you're measuring total at that moment, besides talking about symptoms, you have no idea how much you have ready to use until you check a free testosterone. And we could get nerdy and talk about calculated versus direct measure. But at the end of the day, you need to look at your free testosterone in tandem with your total, in tandem with your symptoms.
Yeah. So that's a great question to ask up front, is when a provider says, we're going to pull your labs.
And you're like, what test do you order? Right. Yeah.
What do you order?
So free testosterone is an obvious one for me. I think the next one would be if you're a female, and particularly if you have an intact uterus, but even if you don't, okay, and you're getting estradiol or estrogen therapy, and you're not receiving an adequate amount of progesterone to offset its proliferative effects. So what do I mean by that? Well, estradiol, which is the major active estrogen in human males and females, has a habit of making tissue grow in the endometrium, in the uterus, in the endometrium. You can grow it. It thickens. And if you don't offset that process, you can develop endometriosis, you can develop fibroids, you can even go on to have like endometrial cancers. It also correlates back to ovarian cancers when you don't have adequate progesterone. So what I'd say is, if a provider is just randomly giving you estrogen and not adequate progesterone to offset that hypertrophy or oppose estrogen, so to speak, in the literature, I'd go somewhere else. I think you're putting yourself at risk. And there's even evidence in other tissue planes to do the same. There are progesterone receptors in other places besides the uterus, guys, besides the endometrium. So I won't use estrogen by itself. I will use estrogen in combination with progesterone. I don't do it. I would not recommend you go places that do it that way.
And on that note, another one for women. I don't know if I've told you this story, Jerry, but a gynecologist. Now, granted, I wasn't looking to her to be my hormone provider. I already had one, but when she saw my progesterone that I was taking when I listed out my medications, she tried to hand me. She said she was quote uncomfortable with that, and she tried to hand me a prescription for something called Provera.
Yeah.
One of the ingredients being progestin.
Yeah.
So
yeah.
You want to talk about synthetics versus bioidenticals?
So this is an easy one. The synthetic progestins are not in any shape or form equal to or apples to apples with progesterone that you'd actually find in your body. And one of the obvious changes would be when they break down. So when these drugs metabolize, or when these hormones metabolize, progesterone has a very specific pathway to make alloprogesterone, or another word you'll hear is allopregnanolone. That's the neurosteroid component of this that helps your brain release more dopamine, more serotonin. You don't get the same pathway with progestins. They don't do that. They're not acted on by 5-alpha reductase in the same manner to make those neurosteroids. So you don't get the sleep benefits. You don't get the mood benefits. You may control the bleeding and it can act as birth control, but it is not doing all the same work or binding all the same receptors because it is not the same drug. So people that equate birth control and progesterone need to go back and really look at that pathway and understand what's truly in medroxyprogesterone, acetate, or norethindrone, because I promise you, it is not progesterone.
Because progesterone is also progestational.
Progesterone. That's right.
That's right. So back to the men for a moment. A lot of providers want to block estrogen.
Oh man,
Does it drive you crazy?
It drives me crazy. So in years past, have I been guilty of thinking that way? As a 20-year-old in the gym trying to get strong, get big, and you listen to your friend in the gym and they go, "Yeah, we got to get rid of our estrogen, or we're going to have breasts. We're going to go breast tissue. We are leaving our strength gains on the table if we leave our estrogen intact." And that couldn't be farther from the truth, guys. I'm not saying that if you went crazy in the bodybuilding world and took massive amounts of testosterone to the tune of like grams per week, and on top of that you're adding anabolic agents that have a prolactin elevation pathway like 19-nor drugs, could you grow breast tissue, guys, in that setting? Yes. Are you going to grow breast tissue, gynecomastia, on repletion doses of testosterone if you don't block your estrogen? No. You could find the right genetic zebra. I never say never, and I never say always, right? Mm-hmm. You can find the right genetic zebra that's DHT sensitive. You can find all kinds of receptor changes. You need to stop blocking your estradiol with Arimidex. It is harmful. It weakens your bones. It demodulates the way you make healthy lipids. You lower your HDL subfractions. You'll make more plaque. You'll have more tau folding. You can have sexual dysfunction with an AI. You can have mood derailment. Like, stop doing this. It's dangerous to do that. Stop doing it. And then back to the leaving the gains on the table thing. Go look at the feedlot studies. Now, animal studies don't always equate to humans. That's very true. But quite often they correlate pretty well. In the feedlot trials, they were giving cattle estrogen, testosterone. Some of them got even anabolics like trenbolone, which is only for cattle, not for humans. And then they had an arm where they used the androgens. They used the testosterone and the tren, but they took their estrogen away. In the groups that had higher estrogens, they had more dry, lean mass. Not water, not fat, not bone. They had higher muscle mass, okay? estrogen or estradiol particularly plays a role in these gated ion channels that allow nutrients into the muscle belly when you're lifting. If you're taking away your estrogen, you are leaving some muscle hypertrophy on the table, especially in the setting of not just growth, but recovery, like how sore you stay after a lift. So stop doing it. It's crazy. You're not going to grow breasts if you do it right. Don't be taking bodybuilder doses. Don't be using anabolic agents and jacking your prolactin up. Testosterone, when done correctly, is safe to do without an AI. This is not personalized medical advice for you, but
Absolutely
I could
not.
say it's a general education statement.
Yes. No, I think that's going to blow some men's minds hearing that.
It should. If you're still blocking your estradiol, you are living in the 1970s of the hormone world, and this is not the way to do this.
Nothing against the 70s, but
70s are pretty cool. Yeah, 70s and 80s with Arnold. But
yeah.
I think Arnold today would tell you quit blocking your estrogen as he did in the 1980s.
Right, right. Do you happen to know, this isn't medical advice, but do you happen to know any men who have played around with some estradiol? And if so, what was the result?
Yes. So let's not say who, but let's say I know some men that have purposely elevated their estradiol by taking estradiol along with their testosterone, and they had excellent improvement of their lipid profiles. Their HDL subfractions went up. Typically, their sex drive goes up. Um, I didn't measure bone density in these men to see any change, but they probably had such high bone densities anyway. You were not going to see a whole heck of a lot. But yeah, they felt good. They didn't feel bad. And by the way, they didn't grow breasts. What I can also tell you in our little niche of the world, our little sample, 20,000 encounters in, literally, or 20,000 patients in, I'm not seeing gynecomastia in our population of people. I talk to all our providers nationwide. I track a bunch of patients myself still, not seeing it. So it's not in the literature. It's not in our little sample size. Stop doing it. Stop doing that.
Let's cut that out.
Yeah, sorry, end rant.
One more on men as far as red flags, and it has to do with fertility risks.
Oh gosh, yeah. I think another one. If you're going to a provider and you're young, to me, young's in your 20s or early 30s, and I typically don't like treating those men with testosterone unless they truly need it, because you can shrink their testicles and hurt their fertility odds. Now, is that truly permanent? Well, typically not, but it can be. And so the best idea is, if a provider doesn't say anything to you and you're 22 years old and you go to one of these clinics and they're just cranking out testosterone on every single person they meet, I'm sorry that happens. It's inappropriate, but it does. And they say nothing about the fact that your sperm count's going to be like 0. Go somewhere else.
Mm-hmm.
They don't have your best interest at heart. They're just prescribing to, probably, unfortunately, for profit. I think testosterone clinics a lot of times get a bad rap because people just in the community, the medical community, just assumes, oh yeah, those places, they just treat everybody that walks in the door. That's not true. It can be true in some places, but not in this one. I can guarantee you that. But not in a good, reputable place. I think there's plenty of reputable providers that say, hey, we're not going to inadvertently treat young people without considering their fertility, or maybe altering them, offer alternate services. Like you could use clomiphene or perhaps HCG, or in the combination of those without the testosterone to get them some increased testosterone and not hurt their fertility. So yeah, if you're going somewhere and they never talked about that, and you're a young male that wants to have children, caution. Yeah. Caution.
As much as we love testosterone, it's not
absolutely
a be-all end-all for every person.
It's not some magical cure-all thing. Not everybody on the planet at every moment of their life needs to have a prescription for it. It needs to be appropriately used.
Right.
Duh.
Love that. As always, appreciate your sane,
I love
measured
these. It seems like I always get on a rant and seem mad. I'm not mad. He's
a jolly person.
I am. I'm a happy person. I'm just agitated and passionate about what we do.
Yes. Well, we love that about you. We're here for it. Thanks, Jerry.
Good to see you.